I'm Steve Woolf. I'm a professor of family medicine and population health at Virginia Commonwealth University. I trained in public health early on after I did my initial clinical training and got my MPH at Hopkins. Then went on to go into family medicine and clinical practice and did a lot of practice-based research, part of which is what I was talking about with the family medicine folks earlier today. Trying to improve the quality of primary care and so forth. But as the years went by, got increasingly concerned that the health of Americans was not what it could be, and in particular, the gap between the health of Americans and that of people in other high-income countries. And I got interested in this before the crisis got really bad. But it was at the time I first became aware of it, I thought it was really bad. I didn't realize it was going to get far worse. But before I go further, I wanted to honor my host here because Stephen has been writing about this for a long time. So, the book on the left talks about what he calls the Health Olympics. But on the right is a paper from 2001. Is that right? So this is, 25 years ago that this was on his radar. So this is someone who's been concerned about this for some time, and he and I sort of have developed, sort of bonded around this particular issue. Let me just set the stage by showing you life expectancy data. This is based on UN population estimates for various countries with a population of 1 million or more. And you can see the US is not in a good place. And that's sort of the context for this discussion. It's important to understand how that gap has evolved over time and why I keep referring to it as a crisis. So this is plotting life expectancy for the United States and 16 high-income countries. The red line is the United States. There's two versions of the red line. One is based on the UN population estimates. The other is the estimates from the CDC, from the National Center for Health Statistics. This graph was used in a paper, and part of the point of that is to validate the UN population estimate model, that it's closely mirroring what the CDC is reporting. So the book that Stephen held up was published in 2013. So you can see that's what the situation looked like at the time that report came out. That report was commissioned by NIH as the follow-up to a prior committee that the NIH had commissioned to look at the health of Americans 50 and older. So we were sort of a follow-up committee to look at the issue more broadly across all age groups. But my point is, if you're familiar with these National Academy committees, they work for a good couple years before the reports come out, and the process of deciding whether to commission the committee takes time. So the prior report came out in 2011. So that tells you that NIH was already thinking about this issue in the mid-2000s. So back over there in 2006, 2007 period, there was enough concern about the health of the Americans compared to people in other countries that they started convening a committee to start looking into this. So at the point that our report was released, and our focus was on documenting the epidemiology of the problem and the scope of how mortality and morbidity rates in the US compared with other high-income countries, but then to go beyond that, to start exploring why. What are the explanations for this, and what might be done about it in terms of policy solutions. But you can see that after that New York Times article and so forth, nothing really happened in terms of policy to actually move the needle on this. And in fact, life expectancy flatlined at that point. After 2010, really, there was very little. You may remember in the period between 2014 and 2017, there was front page coverage of the fact that life expectancy was decreasing in the US. That was breaking news at the time because it had never decreased before it has been increasing for the past century. And that decrease now seems trite compared to what was later going to come during the COVID pandemic. But at the time, it was big news that life expectancy in the U.S. was falling. And then, of course, you see what happened during the pandemic, where every country took a hit in terms of life expectancy. Not every country, but most countries. Yeah, there are other countries. There are countries that continue seeing their life expectancy climb during the pandemic. But in any event, the U.S., as you can see, experienced a much larger loss, so that the gap in life expectancy between the U.S. and other countries widened a lot in the decade preceding the pandemic. It was raising a lot of alarms, but dropped considerably. Anyway, when we wrote this report, and we were trying to sit as a committee and think about, well, why is it that Americans are sicker than people in other countries? And the epidemiologic analysis that we had done showed that this was true for dozens and dozens of health conditions. So it would have been easy if it could have been like, oh, it's obesity, it's firearms, it's opioids. But the problem was there were so many conditions. We were talking about this earlier. We looked at, road traffic accidents, and we had transportation engineers who studied the U.S. versus highways in other countries, telling us Americans per mile are more likely to die as motorists than motorists in other countries. We cross so many pathologic systems, injury categories, and so forth. The U.S. was being outperformed, that we felt like we needed to take a comprehensive approach to thinking through what are the drivers. So this is the conceptual framework that was used in our report. And it's a pretty simple one, but basically it's saying if you look at health outcomes as your ultimate, distal outcome that you're looking at, there are 5 buckets of things to think about that shape health. Healthcare, health systems is obviously one of them, and that includes public health along with healthcare systems. But we know that only accounts for 10 to 20% of health outcomes, so that can't be the whole answer, but that's one of them. Individual behaviors, smoking, diet, physical activity, and so forth, we know are hugely important to health. So that was one domain, is, what are our behaviors? But we understand that our behavioral choices and our access to healthcare are shaped by socioeconomic conditions. And so that the social and economic factors need to be thought about, what's going on there. And it's very much shaped by our environment, the built environment where we live, both neighborhood level influences, but also our social environment, discrimination, social isolation, things of that sort. And then all 4 of those are influenced by public policies and social values and so forth. Those each became chapters in our report, because when we looked into each one of them, looking for the explanation for the U.S. health disadvantage, we found multiple potential possibilities in each of those buckets. So if you're talking about access to healthcare, we were the only country without universal healthcare. We were the only country with fragmented healthcare system, inadequate primary care, financial barriers to accessing care much higher than in patients in other countries. We looked at individual behaviors. We found higher per capita income, higher civilian gun ownership. Go through the list of behaviors that are different for Americans than they are for people in other countries. Socioeconomic conditions, their highest child poverty rate, highest level of income inequality, and the same goes all the way through in terms of the environment and public policies. We did an extensive discussion about how we go about approaching policy in this country that differs from other high-income countries, the role of the Constitution, which creates conditions in the U.S. that put us at a systematic disadvantage, and so forth, were all examined. Anyway, we made a bunch of policy recommendations about it, and others have as well, not just this book. Many other authors and scholars were saying what we ought to do to try to close the gap. And some of those items are listed here. But the frustration for many of us in the field was that little of this happened, mainly because they're political non-starters in the United States. These tend to be, especially with the politics on Capitol Hill, even at that time, this would be even during the Obama years, the politics were not good for trying to promote these policies. and they didn't improve. But the health disadvantage did not get any better. So this is a committee that I served on later that was getting more and more alarmed about rising mortality rates in young and middle-aged adults. This had not been on our radar when our report came out. We had little hints of it. But by the time this report came out, as you can see from the graphs, we were documenting something really seriously concerning. This is the work, if you were following Case and Deaton's work around 2015, they got a lot of media coverage, rising mortality rates in middle-aged Americans, which later expanded to become young adults and middle-aged Americans. Basically, the 25 to 64 age group was seeing dramatic rises in mortality rates. Deaths of despair and other terminology like this emerged during that time. And again, the same kind of policy recommendations were put forward, but it didn't happen. And then came COVID. And what was interesting about COVID was that many of those systemic issues that we talked about in the earlier reports and that had been documented and that were being raised in policy discussions at institutions like this one and many others around the country that were trying to raise alarm about what was happening. Many of those systemic factors actually made the US a sitting duck for the COVID-19 pandemic. There's the additional layer of choices the Trump administration made at the onset of the pandemic in terms of pandemic control policy that we could talk about that didn't help matters at all. But there were systemic issues. So whether you're talking about the frontline workers who were, overexposed and the reasons why we had such high COVID-19 mortality rates in the Hispanic and Black population, the inability of people to get testing and so forth, a variety of the structural factors that put the U.S. health disadvantage into such a crisis state before the COVID-19 pandemic expanded the impact of the virus in our population. Even those cultural values. We wrote in this book back in 2013 about how the tendency of Americans to want freedom and liberty and not to be regulated in terms of their behavioral choices. And then what emerges during the controversy about masking and vaccine mandates and so forth, many of those same issues, except intensified, obviously. And so the crisis deepened. So along comes the Biden administration trying to recover from the COVID-19 pandemic. Some progress was made. There's some good news. We saw some after the peaks during the height of the COVID-19 pandemic, some decrease in drug overdose death rates, increased attention to obesity, and some attenuation in the dramatic spike in homicide rates that had occurred in the preceding years. So there were some important trends, but a lot of the policies that we felt needed to move forward to really address this still were unaddressed. But the arrival of the new administration has created a new challenge that I think has taken this to a new level, which is before the problem was inaction. Not enough being done to pursue policies to promote health and reduce health inequities. Now the problem is action, is overt policy choices that are being made that actually compromise population health even further. So in the quest to understand the drivers of the US health disadvantage, the concern now is that we're seeing a massive influx of new policies that could potentially magnify the US health disadvantage, making what is already a bad situation even worse. So one way of thinking about it is looking at that list of policies that we talked about earlier and think about, well, this is what the experts recommended on the left. What have we done? So in terms of access to healthcare, the recommendation was to promote access to healthcare, but instead we're seeing cuts to Medicaid, the lapse in the benefits for the ACA premiums in the marketplace have limited health insurance coverage. And so that is not moving in the right direction in terms of broadening access to healthcare. We talked about the social determinants of health and the importance of education as a major driver of health, recommended increased effort improving the quality of educational outcomes in the United States, but the administration is pushing in the opposite direction in terms of dismantling the Department of Education. In terms of that bucket of socioeconomic conditions and child poverty and income inequality, the new administration's economic agenda has, as we know from reading the news each day and what we see in our own lives, created an affordability crisis where now the cost of living is even higher than it was. We haven't seen real wages, income, inflation-adjusted income for most of the population markedly improve. The employment situation has become rather unsteady, and so there's been a problem in terms of job stability. Not to mention the recent development of the economic ripple effects of the Iran war, all of which has not really addressed the root cause that we were dealing with there in terms of the role of socioeconomic conditions in compromising the health of Americans. Income inequality was something that we talked about, and yet, the economic agenda seems to have concentrated wealth to a greater degree now than it was before. And the tax bill that was passed last summer, some economists describe as the largest wealth transfer in U.S. history, is a large amount of income that's been concentrated among very wealthy Americans and corporations. But for the vast majority of the population, their net assets have gone nowhere, and in some cases are shrinking as a result. Food and housing security are very important social determinants of health, but we saw the big cuts to SNAP. HUD experienced big cuts as well, and housing affordability is now quite precarious. We said that one of the reasons other high-income countries outperform the U.S. is their stronger social safety net, but we're rolling back our social safety net. Health inequities, systemic racism were words we were allowed to say in our report, but obviously have been targeted in this administration in terms of the anti-DEI programs, as well as other initiatives trying to deal with marginalized populations like the LGBTQ population. When we were looking at issues like road safety and high injury rates in the US compared to other countries, we talked about the fact that other countries do better in terms of regulating health and safety than the United States. So we recommended that we try to model some of that and then tighten our regulations. But this administration is interested in deregulation. The EPA announcement shown there, this is taken from the EPA website, proudly boasted that they were announcing the largest deregulatory effort in US history. And with that has been rollback in environmental regulations that affect our health, both in terms of pollution, but also where we're going with climate change. The Trump administration pulled out of the Paris Accord and is really promoting fossil fuel production. And this has implications both for us here domestically in the US, but also worldwide, because it's obviously a planetary issue. So this is not what you'd want to do if the goal was to improve population health. There are reasons why these ideas are promoted, because there are other goals in mind besides population health. But for those of us who are concerned about population health, this is not what you'd want to do. There's an interesting paradox about the MAHA movement, because the data I've shown you are the kinds of data that Secretary Kennedy quoted in his confirmation speech. It's actually foundational to the MAHA movement, is the evidence that the US is not doing well. And he often refers to the fact this is a sick country. So he's right about that. And the idea of making America healthier is very much something that we have devoted our careers to. That's exactly the right goal. That's sort of the paradox of it, is a good idea, But the plan is not really dealing with the structural factors that drive health. There are good points to it, so it's important to be fair. I mean, well, I'll get to it in a minute. In terms of food policy, um, the food environment is toxic, and people have been in our field have been writing about this for many years. The role of the food industry and advertisers and political cross currents that actually incentivize low cost, high calorie dense foods in promoting the obesity epidemic. So a lot of that is a good thing to do. The concern about pollutants and toxins in our environment is very valid. But the problem is it's set against a set of policies that are ultimately harmful and threatening to population health. It's hard to get onto one slide all the stuff that's been going on, and you get deluged by it on a daily basis. But if you just step back and look at the overall picture, you have, a real disruption, some would say dismantling of our infrastructure for premier health agencies in this country has occurred in the past year. We've lost thousands of career staff, scientists, and so forth. There have been very big cuts to programs dealing with chronic diseases and injury prevention and many of the other issues that we all agree are important, including the mental health crisis, which was the topic I was speaking about in a prior presentation. I don't need to tell you about cuts to research funding that our universities have experienced. The mRNA research program being canceled means that for the next pandemic that comes along, we're going to be slow in getting a vaccine produced in time. Data collection has been hampered. Public health policy itself, whether you're talking about the ACIP, the U.S. Preventive Services Task Force, Tylenol, I go through the list, we're seeing policy being advanced that's not evidence-based. Although the right words are being used, it's an attempt to pursue gold standard science, but it's actually a departure from evidence-based policy. And then, with the vaccine hesitancy and other erosion in confidence in public health, we've seen behavioral changes in the population in terms of vaccine hesitancy, lowered levels of immunity, more people seeking waivers on childhood vaccinations, and then, of course, the predictable outcome with vaccine preventable diseases will be an increase in outbreaks, as we're seeing with measles. It's not limited to our country. The administration very quickly, the executive orders from the get-go were to end funding for humanitarian aid, for global health research. The gutting of USAID had massive implications. The map on the right is from a Lancet paper that estimated 14 million deaths would occur as a result of those cuts to USAID funding. As I mentioned earlier, the promotion of fossil fuel production and opposition to clean energy worldwide is going to have adverse health consequences. And then this was all true before we started military activities that obviously also affect civilian health. So when you look at trends like this, you have to think about, well, what do we do about it, especially now with the current circumstances, and what are the root causes? And it's important for historical purposes, especially for younger researchers, to realize that this is an old problem. It's not new. It didn't come with the Trump administration. It didn't come with COVID. Those have added new layers onto it. But some of the work I've been doing recently, going back to historical data that compares our cause-specific mortality rates with cause-specific mortality rates in other countries, is very revealing in telling us the timeline for when these gaps started developing. So you can find in the 1960s the evidence that our homicide rates and transport mortality rates, death rates from diabetes and so forth, were already parting company with peer countries in the 60s. And on it goes. You can see in the 80s for infectious diseases, renal failure, neurologic conditions, respiratory diseases, we were being outperformed by peer countries by then. In the 1990s is when the drug overdose problem emerged, and we started falling behind there. In the 2000s is where you start seeing a departure in our rate of mortality from mental health, namely alcohol-related deaths, as well as suicides and falls. And then the 2010s, digestive diseases, which is really driven by liver disease mortality in the US being much higher than in other countries. So all of this tells us what? It tells us that there's something systemic about life in America that's not new, that's been going on for many years. It's just getting worse. That gets us in the state that we're in. So what do we do about it? Well, there's two ways of thinking about it. Some people, the reflex is to think about, well, what are the leading causes of death that are responsible for this? And let's take them one at a time and let's think about policy solutions. So the topic I talked about in the last hour was youth mental health. So what do we need to do about the youth mental health crisis? Opioids, alcohol, what do we need to do about substance abuse? And there's a variety of policy solutions that we can think about there. The role of suicides and homicides, which have increased significantly, especially among adolescents and young adults since 2007, roughly. Well, suicide 2007 and homicides since 2014 have been climbing. And the role that firearms plays in sort of fomenting that. Transport-related deaths are higher than the US, so those road traffic engineers have a lot of ideas about things we need to be doing in the US to help reduce that, which still remains a leading cause of death among young Americans. A whole spectrum of obesogenic diseases, ranging from the classic ones like diabetes to many cancers and other chronic diseases that are driven by this obesity. Hypertensive heart diseases, hypertensive renal disease is a major contributor to the mortality gap in the US, so we can think about the need for hypertension control. And now, a new bullet for my slide, infectious diseases, which didn't used to be on this slide, but given the current environment, now becomes one. What do we need to do about maintaining immunity and herd immunity levels and setting a more stable vaccine policy in the United States? So this is a cause-specific approach. The food pyramid, the new food pyramid that the new administration has released is, got some merit to it. I think there's some concerns about some of the elements of it, but yeah, a healthy diet I think is important, certainly for that obesogenic disease bullet, hypertension control, a variety of others, but it's not going to affect most of those bullets. That's not a sufficient solution. The premier health agencies under this administration are being forced to turn their attention on issues of particular interest to the political appointees. In this case, in the picture, Secretary Kennedy. So we're having a focus on the role of antidepressants, for example, being overprescribed, and other issues. Not that these aren't important; they do merit attention, but they're not getting at the other stuff on the slide. And in fact, it's not only not getting at it; it's actually countervening what we ought to be doing on those things. So if we talk about firearms, for example, the leading cause of death in American children is firearms. The MAHA agenda, if you look at the actual strategy report that was released in September, do a search for the word firearms. In a book about how to make American children healthier, it comes up once, firearms, in a reference to ATF doing something about vaping. So alcohol, tobacco, and firearms, the agency, that's the only time that the word firearms appears in the report. Nothing about it. In fact, the administration is seeking the opposite, which is to roll back gun regulations. So what we ought to be doing in terms of dealing with the problem, as I mentioned, is dealing with the root causes, the systemic factors that are responsible. On the left, again, is the list of issues that we raised years ago that I said were political starters, non-starters back then. They certainly are now. But that really is the way forward. And what I think brings me some bit of optimism is that it's a non-starter in Washington, D.C. It's a non-starter at the federal level, but states are still free to pursue these policies. What we're going to see is a bifurcation, I think, between the states. This is some work that we did during the COVID-19 pandemic, where we were looking at mortality trends broken out by partisan orientation. By the way, this is a topic, politics and partisan orientation. I was trained that has no place in scholarship. So for most of my career, I avoided mention of any of this in my professional work. But the recent years have turned this into a social determinant of health, or so basically a political determinant of health. Just like you can predict outcomes based on education or income or other classic variables that we use in social epidemiology, especially during the COVID-19 pandemic, when pandemic control policies were determined by whether the governor had an R or D after their name. You didn't need to know the state or the governor. If you knew it was an R or a D, you could pretty well predict what they were going to do on mandates, let's say, or masking and so forth. And sure enough, when we looked at the analysis, you could see this stratification of the outcomes based on partisan orientation. So I think what's going to happen is you're going to see a differentiation between states where some will make certain choices and others will make different choices that will maybe ease some of the disadvantage that exists. All of our states, including the healthiest state, Hawaii, do worse than the peers in high-income countries, but the gap is smaller for states like your state and Hawaii and New York and so forth. Whereas states in the Deep South, for example, West Virginia and so on, their peers are Libya and Syria and so forth have comparable life expectancy to states in our Deep South. I mentioned New York, interesting story. If you go back and look at the data, in 1990, New York and Oklahoma had the same life expectancy. I don't have the slide to show you. It's a cool graph. Same life expectancy. Then they sort of part company. New York's life expectancy starts climbing. It's for some years had the third highest life expectancy in the country. Oklahoma 47. And New York was down there back in 1990. So why? Why the change? So if you're a good epidemiologist, you'll think about compositional differences in the population. New York's statistics are very much influenced by New York City because of the huge population. Demographic changes occurred in New York City. It didn't happen in Oklahoma. These are states from different regions of the country that have different economies. Oil extraction industries are important in Oklahoma. Different industries are important in New York. So some of that departure has to do with contextual factors, but most people think a lot of it has to do with policy choices made by the state of New York and New York City around tobacco control and a variety of other issues are probably largely responsible for the fact that New York parted company with Oklahoma. And that kind of variation, I think, is likely to continue to be important. We're now living in a time post-COVID where a lot of policy issues, whether we're talking about reproductive health rights, gun control, climate policy, and other civic issues like voting and so forth, are going to be made in these state capitals, in these state legislatures and governors' mansions, and are going to probably, and at the local level too, are probably going to exert greater control over health trajectories than what happens in Washington now.